So things like, is it giving you trouble breathing or anything else like that? Change in appetite, weight loss is important. Cough, any sputum production, any blood in sputum. Does she have a problem swallowing with any of this? So could there be a mass that's actually giving her problems? And does she have any lumps anywhere else? Could it already metastasize? Does she have lumps in her armpits, in the neck, cervical chain, anywhere else? Are there any associated symptoms like we talked about, allergic rhinitis, postnasal drip, family history of any malignancy? Has she had any neurological diseases in the past? Any thyroid or neck surgery in the past? So anything that could possibly give you or lead in. What you're doing by asking these questions are looking for lead-ins into where is this coming from, and the patient already knows the answer to that because this is a structured case. What they want to know is, can you think of those things? Can you ask appropriate questions so that you can get a lead in, and they will give you the information that you need to answer that question. So if it's a specific thyroid case and you ask a thyroid questions relating to the thyroid, you've asked the right questions, they will give you the answer and go, yep, that's what it is. So that's what you need to do here as well. Physical examination, again, general appearance. Are they looking anxious?
I'll be doctor, I will be taking over there.
Yeah, sure.
Okay, because I need to explain them how to systematically ask this. This is where the people candidates are making mistake. Okay, one thing, this lady would not be in a distress in the room. She will be talking to you. You might not come to know that she's having. Okay. You will not come to know whether she's having a hoarseness of voice because of cancer or it's just that she would be comfortable. But they change the presentation. Sometimes they keep a shortness of breath patient sitting in the front. Please do need to ask about this case. If shortness of breath is a first presentation. If it's just a hoarseness of voice is your concern, just be keeping in mind hoarseness of voice could be present, but you do need to assess the shortness. So ask the examiner, is my patient is vitally stable in the beginning itself, just to save your life in case you are going in mid. Now, general appearance patient will be looking anxious. Why this is happening? Hoarseness of voice, they are not able to talk. Okay. And while you're looking at the general appearance, you can ask the examiner, is there any Horner syndrome being present? Why? There are two cases we have. Penco's tumor and squamous cell carcinoma lesion on the neck as well as the thyroid. So you need to actually be looking for, because pressing of recurrent nerve nerve in syndrome and the brachial plexus can give you the signs of that. So any signs of shortness of breath is in them. If vitals being normal, then you go receive asking for a hand examination for clubbing, because she's saying that this is being happening gradually. So you definitely will have a clubbing sign present. Be systematic. Rather than step by step, you will ask, I would like to thoroughly look for detailed ENT examination. I'm looking for tympanic membrane, tonsillitis, and pharyngitis in the mouth. Then going on the neck, I'm looking for thyroid. Okay, look for that. And then you will be checking use and the trick. Followed by, then you go to chest. Chest, I'm looking on the inspection, any deformity, because we know the restricted so we will be checking any deformities. Then we will be checking for the bilateral air entry. Followed by, you will be actually looking for any signs of tactile vocal fermetus and tactile vocal resonances, any dull note, any hypernescent note, because you do still be systematically ruling out any pneumonia cause, any cause of loss of breath sounds or bronchial breath sounds. You will be checking for that. Okay. Then coming to auscultation. Auscultation, you will be, and all these parameters, you will be finding the only dull note being present on the like percussion. And in tactile vocal parameters, you will be finding the dull voice. Again, on auscultation, you would not be finding the uniform sounds. They will be added sound, either V's or capitation or mixed sounds. Again, in this presentation, the examiner gave you the dull sounds and the losal bear. So you need to find out middle lobe or lower lobe. Okay, this is very systematically you have to do it. Okay, decrease air entry. Now, abdomen, you won't find any finding lymph node palpable. In this particular station, they did not give you any lymph node. Why? Because it's a small cell squamous cell carcinoma. But in some cases, when you have adenocarcinoma case as a similar presentation, you will be getting lymph node palpable, especially supraclavicular. Keeping in mind, supraclavicular lymph node palpable means it is already a stage 4 cancer, okay? That is last stage. And the patient would not be going other than not only anything surgery, it's not stage 1, stage 2. You would be just offering chemotherapy and radiotherapy. Your management course will be completely different. So this is coming as a breaking bad news case. So immediately you will be asking examiner if it's just chest X-rays there or CT scan is being given or sputum sample. If it's not there, please order. That's office-based test you need to be doing, just X-ray right now. CT scan and sputum, that's what investigation they want you to order. Remember that you have to order it immediately as soon as you see there is a problem with the lungs. It's keeping in mind simple. So, Dr. Andrew, you will take over from here. So what are the relevant investigation we will be talking, Dr. Andrew, and investigation?
Yeah. So what investigations do you think? We've talked about a few here. What do you think are the most appropriate that you guys are going to ask for? Anyone want to type anything? What do they think they'll do in this case? Anyone? Okay. So full blood count. You're going to talk about the sorry.
She's saying voice is breaking actually. Are you everybody
Yeah, that
able
was for
to
that was
listen?
for you earlier. That was for you earlier when she wrote it.
Okay.
Okay, so are you guys happy with the investigations? Is there anything you want to know about why you wouldn't organize some of these things or why you would do these certain things? And what office-based tests you would do?
Why lateral neck X-ray?
Sorry?
Lateral neck X-ray. I mean, what we are going to get in that?
So what you're getting in the lateral neck X-rays is there. You can see the esophagus being for tumors that you might see or any
Tumor, foreign body.
Won't we be getting this on the CT chest and the other directly in the wrinkle scope?
You won't get that on the CT chest. You'll have to ask for a CT neck specifically.
Okay.
Yeah. Look, I think this is an exam-specific thing that they want a lateral neck X-ray, and what you're really doing there is you're looking for, as Rasma said, any foreign bodies or any sort of impingements that you can clearly make out. So if there's anything impinging on the trachea or the esophagus, or the epiglottis region.
I'm talking about hoarseness of voice. So you need to be taking lateral X-ray. First is X-ray, basics investigation, because we expecting thyroid tissue trauma. Now, not to
Your voice is breaking. You just need to switch on, come back here again.
My voice.
Yeah, just got pauses are coming in between.
So yeah, look, lateral neck X-rays are one of those things that I think for exam they're asking you the question. In reality, to be honest, I don't think I would be ordering a lateral neck X-ray because these days we do a lot of CTs and bronchoscopies. Laryngoscopies. So I don't really know why it's just an exam specific thing. I think you just have to bite the bullet and accept it, that that's what they want in the exam. I don't think I can give you a
No,
better
no,
answer.
Dr. Andrew, I'm explaining her why we doing it. We can't be jumping into test immediately. It's a step-by-step approach. We're taking chest X-ray. We're taking X-ray of a lateral neck. We're talking about trauma, foreign body as the first of your differential. Then we're doing the staging. When we do the staging of any disease, we do the CT scan. We
No,
can't be just
Rachna, what she's
jumping into
asking
it.
is
Okay,
what is
that's
it
a
really?
cancer.
Yeah, Rachna, what she's really asking, what is the importance of a lateral neck X-ray early on in the picture? Because technically, if you're going to
Yeah,
be worried
yeah,
about
that's what I'm
something,
explaining only.
in reality, I'm just saying, in reality, you wouldn't be doing lateral neck X-rays that often. You'd be going to other modalities, but for an exam-specific reason, they're asking for a lateral neck X-ray.
Yeah, I get it. You both are like first we do the both X-rays. We'll say that we are going for chest X-ray and the X-ray of a lateral neck to find out to rule out any foreign body obstruction, and then we'll be going for the CT scan.
Yeah,
And
pretty much. That's what you're saying
Yes,
for the exam
that's
purposes.
the
Yeah.
protocol. That's the
yeah,
protocol.
thank you.
Yeah, that's a stages because that's how we do in MCQ. Start with the X-ray, then we go CT scan, then we do bronchoscopy to find out what is the tissue look like.
Yeah,
Okay.
So I think
Any
you know
any other person? Any questions other than Sunain?
Just say that.
and you just have to be mindful that you're referring to a specialist as well. You're again in a GP setting. You're not trying to find all the diagnosis here and now kind of thing. You're referring to specialists as well too. Now, the big thing about managing this case is you're going to either find an abnormal finding. So you're gonna ask the examiner at the end of the day, these are investigations I want to do. Do I have results for any of these investigations? And the examiner may pass you, give you some exam results. Okay, so then this might turn into a case where you have to discuss the results as well as part of that case. And they might give you an X-ray, which might actually be an absolute normal X-ray as well, or there might be pathology on it that you can easily decipher. But what you're really trying to do is once it comes to explanation, it really turns into a counseling thing because this patient's worried about it. The most common things people will be worried about will be cancers. And what you're trying to do is, yes, it could be cancer, but what else could it be? So in this case, I think they've given you an abnormal X-ray. There seems to be a pleural effusion.
Yeah, based on X-ray, if it's squamous cell carcinoma, you will get the white opacity. I have discussed this case before. Otherwise, if they're giving a dull, and when you find an X-ray, you find out the liquid in it. That means it's pleural effusion. So you're getting two type of cases in the exam. Okay. So having said that, there are type of cancers. This is when you're doing Breaking Bad news, you need to be knowing what cancers we should be covering on. So um, you are expected to see either Pancoast tumor or the tumor in the X-ray, or you're expected to see pleural effusion. The way they like, they will introduce that in your X-ray, and they will give you the finding as soon as you say, "Doctor, I need to see the X-ray." They will throw in on front of you. Okay, this is an X-ray. Explain to the patient. The counseling part. This is what we, Dr. Andrew, will talk about, Doctor.
Yeah.
Dr.
So, and
Andrew?
I guess the thing is, they're either giving you a straightforward issue, as in here's a tumor, look at it, and you say to the person, look, I see a shadow on your lung, and we need to find out what this is, or they're going to give you a complication of a possible metastases. And so if there's a pleural effusion, then that's that you're going to be suspicious of there could be a cancer that you can't see on the X-ray, but the complications are this person's already developing effusion, and it could be coming. It could have already metastasized, or it could be coming from. It could be a laryngeal cancer that's metastasized to the lungs already. You want to talk to them about, okay, we've seen a fluid on the lungs. We don't know where it's come from. We need to drain it and send it to the lab to look at what kind of cells are in these fluid, and is it infection growing in there, and or could there be any abnormal cells? you have to be upfront to the patient saying, yes, there could be a possibility of cancer as well, because that's what they're going to be thinking about. And the examiner, the case, the role player might throw things at you. So they might say, well, look, I've possibly had some pneumonia in the last 2 weeks or something like that. I took some antibiotics. I don't have any fevers at the moment, which is what's mentioned in this slide. You can say, okay, yeah, look, it could be a possibility that it's secondary to an infective process as well, or post-infective process. But obviously, it's very difficult to say at this stage what it is. We may need to do further tests after we drain the fluid. We might need to do a CT scan to look for, are there any abnormalities on your lungs? And if there are, then we again need to take samples of those. To do all of this, I can't do this in a GP setting. I need you to refer to a hospital. And for a specialist for a biopsy, I'll need to refer you to the hospital on this occasion, and they will then do the necessary. Types of lung cancers, you need to know what are common and what are the most common things. So small cell are 15%, but they usually present with metastases at the time of diagnosis, and really the way forward is chemo, radiation, and it's usually, it's very rare, but usually end up being palliative. The non-small cell, obviously better outcomes. You can treat with surgery, that kind of stuff as well. So you need to know about a little bit of cancers, what are common ones, and also risk factors for these cancers, right? So if someone has a very significant smoking, asbestos, or exposure to dyes and that kind of stuff, then you're suspecting a different type of cancer.
That's very good point, Dr. Andrew. That's very good point. This is what IMGs don't. Sam, we don't think that other things could be quite associated with factor. And Dr. Andrew is actually, because he's seeing the patient, so that's what happens. You need to be looking for background as well. Check whether occupational smoking, we're going into different things, or pollutants as well can cause. It's not necessary, but this is a breaking bad news. But having said that, examiners are looking your background check, whether are you considering all of these factors or not. And that's why the people in the administration, they fail. Not because they don't know the case. It's in the Karen note, but they're actually not ruling out the causes. Sorry, doctor. I mean, just trying to say that it's a good point.
The other thing I want you to think about it is, okay, so we've talked about the infective side of things. We've talked about, could it be cancers? The other things, could this be just be related to a nerve injury? So again, you want to explore that. Either it's going to be evidence. So if this case comes out to be a nerve injury, then you're going to talk about, it could be possibly from the surgery that they've had. And obviously the reasons are, your vocal cords are cannot come together in the middle, causing low pitch noise, and there could be dullness in the upper lobes. Usually left hilum is where injuries occur. So just keeping that back in the mind, that in this case, obviously this is either going to be a cancer or infective related, but they could give you, if the case talks about a nerve injury, then you need to know what are the most common things. So left hilum and recent surgery, and what they're describing, you'll usually see dullness in the left upper lobe. So that's where the lungs are not sort of expanding as well. So any big questions about this case? It's not a straightforward case. There's lots to think about, and what I always maintain is go in an organized fashion. Go anatomically, so either in to out or out to in, but usually start off with a focus where the problem is, and also think about the worst case scenarios, immediate life-threatening issues, and then the important issues and common ones, and then go on to anything rare. So if you mention those bigger chunks first, you're going to be on the right path of diagnosing what's wrong with this patient in your exam, as opposed to just randomly spitting out stuff. I think that will lead you to not think about it properly, and it's going to make you make you get confused as to what is this case about, right? And a lot of cases will have overlapping findings as well. Anything else? Any questions?
Guys, you guys cannot go blank in this one. Okay. Hospice avoid, think of cancer first, then think of the infectious. But in this case, you have acute and chronic causes. Okay. Any question for us? Then we move to next. We have actually up and down. Oh, sorry, I have to present it because it's there in your exam. Any question quickly, guys? And we have a lot of cases today.
It's okay to ask questions. It's okay to go over something in the case that we've already talked about. We don't mind that. As long as you clear it right now. Just going to these exams.
Low getting in this exam, Rene. Low. The positive finding. If they're not giving positive finding in any, then they're delivering you X-ray, showing that. No. It would be lower lobe in dullness, or the upper lobe they would be giving in Pancoast, but we have a different presentation in the same case. So this is three different presentation. No middle lobe, upper lobe, or either lower lobe they're giving it. In this particular case was lower lobe. Only lower lobe they are giving us a finding. All right, let's move to next. Dr. Andrew might have to actually leave in between as well. Then I'll have to continue with you guys. So
yeah, sorry guys, I gotta run away. I've got work to get to now, but I will join you guys for a longer period of time next time. Good luck. Remember, the exams are all about two things really. You either know the knowledge or you don't know it. It seems like most of you have the knowledge. It's really just putting the knowledge in an organized fashion, exam specific, obviously, but also being safe. And by means being safe is what I mean is thinking of the most important things, life-threatening things, common things, and addressing the patient without making any critical errors, with making sure that you are obviously explaining yourself well, but also referring them on to wherever they need to go. So don't send patients home with chest pain. Don't send patients don't just refer to a clinic that they'll be seen in 3 weeks, 4 weeks, a month, 2 months, 3 months. Send them to emergency department. So don't just say I'm sending them to hospital. Be a bit more specific. I'm sending them to emergency department. I'm sending them to the cancer specialist or whatever. So be a little bit more specific as to what you're doing your referrals for. That will give the examiner the sense of, okay, this person knows what they're talking about. This person is doing the right thing. Sending to hospital can mean anything, and define the timeline in what you're sending them to hospital for. Is it immediate versus weeks versus months versus whatever? So you can say, I'm sending this person to emergency. I will also be making a referral to the outpatient department for this, or requesting an outpatient referral as well. So you can do that. And I think that makes more sense. Have fun, good luck, continue, and we shall meet again.
They will be good. Thank you, doctor. Thank you for coming in. Thank you. All right, so guys, it's you and me now. Okay, so do we still have a voice disturbances? Voice disturbances actually killed our time today. So still we have a disturbances and everyone can hear me properly? Everyone can hear me? Oi. Everyone need an energy booster. All right. Um, let's go on. So, 24 years old male present to in a GP clinic had unprotected sex 3 weeks ago. And your tasks are to take 5 minutes history, discuss the patient with a further plan. What do you think? What is this case? Actually, this came recently and came quite some time. Is we have a different presentation in this exam as well. We expecting in this particular. Sorry, I have actually given. Yep. What we expecting in this one? I am actually not able to something wrong. Yep. Sinister cause. I don't know how many people having here. Counseling for sinister cause HIV. So what we expecting from this person? These they are a lot of yeah, we are expecting STI diseases. What we expecting apart from that? We didn't say doctor.
Counseling.
Okay. When we have HIV counseling, we need to know when this guy would be freaked out. I had in my trial exam actually this case, and that guy was freaked out a big time, and I'm like, doctor, I need HIV screening right away. You won't be actually going right away the HIV screening, and it's like, okay, like first of all, you need to reassure this person we are in a safe fund. We need to actually talk about certain before actually maintain we talk about STI screening or I need to know certain things about you. Is that all right? Okay. So you need to ask a couple of stuff before you make a judgment that he has an STI disease. Is that right? And in terms of voice is breaking again.
Yes.
I think it's okay. I'll hang up and call again. I don't know why this
I
connection.
think it's from mobile as well.
With everyone now.
I mean, I thought it was initially
Back and forth, back and forth, back and forth. Then it's actually
yeah. I thought it's with me initially. That's why I changed from mobile to laptop, and then in laptop it's still again coming at my side. I don't know. Still,
but I can hear you properly.
okay. So that's it my side then.
Okay. And the thing is that yeah, so then you need to put the mic mute as well because in that case, if you will be talking in interruption, will be happening for others as well. I just I'm asking not just you, everyone if they are experiencing the same because I'm connecting and reconnecting back and forth. Is that with same every because I need to make sure that now you were speaking a while ago. If it's okay. Everyone having his problem, some same trouble, or you can hear me properly because it's never happened like that. This is today. I'm like I have connected so many times today, and I'm again, I'm actually on headphones. I'm not even on mic on my laptop or even my connection is good here. Anyway, so let's go on. So this guy will be freaking out like a hell, and he would be like talking about um, I'm having this thing. So you need to ask first of all, ensure confidentiality. Please, in this case, you have to ensure confidentiality in the detail. What you're going to do is you're going to say him, whatever we're going to talk today is going to be confidential between you and me until and unless there is a concern and issue any notification is needed because if you need to tell in the beginning in this case that at certain stage you need to notify the Department of Health And if you do not tell that at the beginning, you might miss the point. The main part of this counseling is not to talk about the STI disease history is there, but you do also need to know that you tell him that counseling session which we are doing Western blot is actually notified by notification. It doesn't happen right away. So you will be the one who will be notifying DHS and they will be doing the Western blot. So you need to take a consent in between the case. You give it at the beginning so that you don't forget. It's the best way of actually approaching. Now you need to know why he's freaking out. So you might need to ask him what exactly happened. Usually in this case, role play would come up with, okay, I'm a young guy. I went to Thailand and I had a casual sex. I went with my partner, but one day I went in the pub and I ended up having a sex with someone randomly. And I was using condoms. Either he will give I was reluctant, or he will say that my condom broke. Okay. And you'll be like, okay, fine. And how long ago it was that? Because you need to know whether it's happened just recently, 2 days, but then he would not be actually happening to have HIV as a AIDS defined syndrome. The thing is actually in a whole counseling session in this one, you need to know the period. AIDS defined syndrome, how long is it a period which we have? Because if he has already developed the disease, then our screening techniques will differ. Okay. And then they will confirmatory tests that will also differ. I have a slide on Western blot today which shows you what we do it in terms of confirmatory the test. Okay. Now talking about like in terms of, yeah, talking about in terms of a test. Now what you will be doing it, so before that you need to make sure that he doesn't have any other STI disease. In terms of other STI disease, what we're looking for, we're looking for we also be looking for chlamydia and Neisseria. So you do need to inform not only just HIV will be coming in, we will be checking for other stuff as well. Now, is that happened in the past as well? Because he's just saying right now, you don't know what is